Welcome everyone to today's webinar, Geisinger's Keys to a Successful EPCS Implementation. I'm Emily Rapley with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Amanda Purcell is EHR Systems Analyst on the Epic Ambulatory Team at Geisinger Health System. Amanda came to Geisinger in 2011 after getting her associate's degree in nursing. She started at Geisinger in the OR and then changed to IT in 2013. Amanda's primary focus is e-prescribing and medication order related. We'll also have Dan Borgasano, Director of Product Marketing at Imprivata, joining us today with thoughts from Imprivata. At this time, I am pleased to turn the floor over to Amanda to begin today's presentation.
Thanks, Emily. So the first thing I'm going to talk to you about is Geisinger. We're a physician-led organization. We now have about 13 hospital campuses, pretty close to about 700 clinics in Pennsylvania and also in New Jersey. We have about 2,400 employed physicians and about 4,000 affiliated physicians. We serve right around 3 million patients, and then we also have our own health plan that encompasses about 600,000 subscribers for that as well. So EPCS, these are just some of the common challenges of paper scripts and some of the main reasons that we flip to doing it electronically. So we've got drug diversion, on the printed scripts. There's also the provider's DEA number. It's really easy for the patients to then copy those and do some prescription forgeries. There's a convoluted workflow to prescribing and then printing out on paper. It's also an inconvenience for our patients. We had patients who would have to call into the clinics. The clinics would then have to print the script. The patient would have to pick it up and then drive to the pharmacy and then also sit at the pharmacy and wait. So switching to an electronic way of doing this is a great satisfier for your physicians and also for your patients. Requirements. DEA requirements for EPCS. So this is a nice diagram. It outlines the EPCS workflow end to end. So starting out with your identity proofing, then your providers using your two-factor authentication, the medication then going to the pharmacy, and then also the reporting that goes on afterwards, which Imprivata does some very good reporting within their consoles for the hospital organizations as well. The solution, so we at Geisinger already have, we're in the process of implementing OneSign before we went live with EPCS. So we had a Geisinger Imprivata team that knew and worked very well with the Imprivata vendor. We also use a BYOD program at Geisinger, so it's a bring your own device. So a lot of our providers were already using their own cell phones and had them on them at all times during their working hours. So the Confirm ID fit very well into our provider workflows since most of it is held right within their cell phones. They downloaded an app. It was very easy. Our providers really liked the workflow. And then they also liked that there was a hands-free selection for them to use too, which we'll cover later in the presentation. But this allowed our providers to keep their phones in their pockets, not out in front of patients. And it did everything for them. So hence the hands-free. So now we'll go a little bit more in depth to Geisinger's approach to successful implementation. So the first thing we had to do as a project team was try to figure out which teams we needed to involve from beginning to end within this project. So I listed the teams there, but I'll go a little bit more in depth. So our credentialing office, they're responsible for putting in our DEA numbers, NPIs, the medical license numbers, all of that into our provider records, which is something that has to be kept up to date in order for your EPCS solution to work. We had to pull in our security team who did our grant and admin request workflows for the providers when they would get set up. And then our pharmacy team, also known as our Willow team, we use them to really dig through our medications and make sure everything was set up right within our ERX records. The ambulatory team, which is the team I was on, we controlled all of the ambulatory side of the build, project leadership, testing, communication with SureScripts, because there's going to be a lot of communications between you and the vendor you're going to use for, or you do use now for e-prescribing, which we use SureScripts here at Geisinger. And then we also did the contracting, the DEA, and then the contracting with Epic for your third-party auditing. And then we had to involve our inpatient, ASAP, OpTime, and ED teams. They handled the inpatient side of the build and testing. We don't use the same order transmittal rules across inpatient and outpatient, so they did their own pieces of that kind of build. And they also help with enrollments, with trying to enroll 2,400 providers. We needed the help from any team we could. Then we had our technical team. They set up our FIPS server, dealt with the certs that are on the FIPS server, location for saving the certs once they need replaced, so those you have to save for 2 years. They also did our auth admin build and worked hand in hand with our Imprivata team, the Geisinger Imprivata team. Training, so our training team developed the online trainings for providers and the clinical staff, which we can go a little bit more in depth to how we did training for our providers. And then support. So we have a service desk here at Geisinger that supports all of Geisinger, Epic related and non-Epic related, but then we also have an Epic production support team. So our production support team was very well versed in this workflow. So we actually, we'll go a little bit more in depth in that too. We trained them, gave them a lot of the common questions, common issues. We created some scripts for them. So if a user would call in for this is the answer. We did some if and then documents. So they covered a lot of the issues to try to keep the primary analysts from the applications out of that piece. So identity proofing and credential enrollment. So you will have users within your systems that will do the enrollment of your providers. They are going to be named the enrollment supervisors. At Geisinger, we allow that to be anyone, but you cannot enroll yourself. It has to be conducted in person. This is not something you can do virtual with your users. Our initial enrollment was the IT staff that did that. So all of those teams you saw on the previous slide, we had folks from those teams. We also had some ops managers and site supervisors that also stepped in to help out. And we tried to attend service line meetings. We did lunch and learns. We also sat up some stations at our hospitals, locations, like on campus, and let providers know when we would be there. We did some all-day sessions. That way when providers, whenever they had a break, they could stop in, they would get enrolled. And we started that about 2 months before we actually went live. And just a little tip there, we used online trainings to educate our enrollment supervisors. So when we first started out to get more enrollment supervisors at Geisinger, we did that as a one-on-one, or we held some lunch and learns where anybody could dial in and listen and then be set up as an enrollment supervisor. We found that it was easier to do that online, so we created some computer-based trainings. So once a user goes in, takes that computer-based training, it sends an automatic email over to our Imprivata team at Geisinger, and then they go in and set that user up as an enrollment supervisor so that they can enroll providers at their clinics or their hospital locations. So then we get to the granting EPCS permissions in Epic. So now that your provider's been identity proof, they have to be granted that access within Epic. So this is done within the SCR record. This process, the granting process and the admin request process are pretty much dependent on your organization's decision as to whether you are an individual organization or an institutional organization. You'll have to go and consult with the legal group to be sure which one you actually are. Geisinger is actually institutional, but we still went with a provider to do our admin request approvals. So what happens is our security team does the grant workflow from within Epic. This kicks off the automatic admin request in basket message. We have a provider informatician that watches this in-basket. He will verify the DEA number and he will approve the providers to use EPCS within Epic. Once that approval is done, there is a staff message that goes back to that provider that was approved to let them know that they've been approved and they can now use it. Until that staff message goes over, then they still will not be set up. So considerations for two-factor authentication. So the DEA requires 2 factors to sign EPCS orders. At Geisinger, the first factor is your AD password, followed by the Imprivata ID phone-based token. And this can be hands-free, push, or the conventional OTP entry. We have all 3 of those, and we typically use the hands-free or the push notifications the most. The hands-free is the wireless connection, so that's the Bluetooth dongle plugged into the PCs, and then the providers just make sure the app's running on their phone. They never have to take it. They don't have to take it out of their pocket. They will literally type in their AD passwords, and Imprivata does the rest for them with pulling in the second token. The push notification, our providers really like this as well. If the PC doesn't have the Bluetooth dongle in the USB plug, when they sign the order and they type in their AD password, it sends a push notification to their phone. That push notification does pop up over top of the lock screen of their phone. So they don't have to unlock their phone and then hit approve or deny, which is really nice, and our providers like that as well. We based our hardware on the number of providers and those clinics that use the high volume. So about a month or 2 before we went live, we ran a year-long report on all of our clinics to figure out which clinics did the highest volume of controlled medications, and we bought dongles for those clinics. And then what we did was allow the ops managers and the providers within the clinics to figure out which PCs they would like to place the dongles on. Us being IT and not in the clinic every day, it was better to allow the providers and the staff there to say, no, we're always using this computer. We place meds every day on it, so we want a dongle on that computer. Some of them are used in the provider offices because some of the providers sign their medication orders from the office. And then we also had some of our staff, if the computer, the tower's down below the desk and you can't really tell if it has a dongle on it, they put stickers on the monitors, so that let the providers know that this is a hands-free one. You don't have to take your phone out of your pocket. You can just sign and the medication order will go. So there's just another tip for success there that we went over, just to work with your clinic supervisors and clinical teams to let them to decide exactly where they'd like to place that hardware. So the EPCS workflow then, so once your provider's identity proofed, they've been approved and granted the access to be able to use EPCS within Epic. Now they're going to go in and sign their controlled medication order. So the first box that's going to pop up for them when they go in and after they click sign is the review medications box. This is something new for the providers. This will list the controlled medications that they're trying to sign. On the left-hand side of that box, in front of each med, you're going to see a little white checkbox. They have to check every box before the sign button will ungray for them. You're going to see a hard stop up there too. That's for their DEA number. This does come pre-populated with the DEA number that's in your provider's SCR record. We still remind our providers just to take a look at it, make sure it doesn't look wrong to them. But we've never had an issue with that. So once they click that sign button, that's when you'll go into your two-factor authentication, where we mentioned before that they will do the AD and then the second factor, whether it is the Bluetooth dongle with the hands-free, the push notification, or the token that they type in off their phone as well. So the provider training and go live, this is something we do heavily at Geisinger. We like to train our providers and make sure they're up to date on the workflows that we're doing. So we did some hands-on training with our providers. Like I said, mentioned before, we attended service line departmental meetings just to present EPCS so our providers knew what was coming. We did also present this to our nurse super users because as a lot of you already know, our nurses are the right hands to our providers, so having them understand the workflow really helped out our providers as well. We do online training courses, so we have computer-based trainings that steps our providers through the entire workflow, including how to use the phone. That's our training team created those. And then we send out fast facts. So these are quick one-page cheat sheets for our providers. So, for instance, we created a cheat sheet on the 3 ways that you could sign for a controlled med just so the provider would know which one of those they were using, especially if there's some places where providers don't have internet or that. This explained it to them exactly how they were going to do the first and second authentication. And then I think there is a tip for success on this one. So this says to establish a war room for Go Live Day, include your vendors, and provide real-time support as needed. So when we have a lot of big go-lives here at Geisinger, we do war rooms. So this is one of those projects that went live system-wide. We did not do a phased rollout. So we did a war room for go-live day, and then that extended the rest of that week, Monday through Friday. It was stationed within the same building as our Epic production support team. So the production support team that I mentioned being part of this project team is in a building altogether. They will get all of our Epic calls. So that's where we stationed our war room, because if anybody was calling in with issues, it was coming to them. And we included, it was ambulatory, inpatient. We had our ASAP Optime ED group. The Imprivata vendor was on site. The Geisinger Imprivata team was on site. We had our project management office here. And we also had our Epic TS that was open on a phone bridge. So that way, any major issues, everybody was there and ready to work it, and there wasn't any hold up for our providers. And then we also held check-ins at 7 a.m., 11 a.m., 2 and 5. And these check-ins were between the project team that was there in the war room and also our provider informaticians and our leadership group. Sometimes when there's issues, our provider informaticians or our nurse informaticians or even our leadership hears about it sometimes before the Epic production support team does. So it was nice to bring them into the loop and you know, they could give us some feedback too. Ongoing support. So our service desk is the first line of support, followed by our production support team, then our ambulatory and inpatient teams, and then Imprivata if necessary. We have an Epic ambulatory full-time, which is me, that's focused on EPCS. We also have backup analysts available if we need them. In 2018, we averaged about 1,200 EPCS orders a day, and only about 0.002% of those failed. So just to give you a little more background on how we handle issues, when a call comes into our service desk and it turns out to be an Epic issue, that will get forwarded to our Epic production support team. They will use all of the training we've given them and also the scripting to try to give that user a first call resolution. So that way the user isn't waiting to be able to do this medication for the patient. If for some reason they're not able to, they'll reach out to myself or my inpatient counterpart to see if there's something we can do for the user. If it happens to be an Epic problem or an Epic issue, we'll have an answer and we'll be able to assist the user in being able to e-prescribe their controlled medications. But sometimes it does have to go to Imprivata support, so our Geisinger Imprivata team can sometimes take over for us to be able to figure out some things on their end. So we just wanted to also give some numbers here at Geisinger too on how much we e-prescribe our controlled meds since we went live. So one of the things we did notice was since flipping from paper to electronic controlled medications and sending those over, we've actually decreased the amount of opioid prescriptions that our providers do by about 50%. Printing prescriptions, we were about 60,000 a month. We dropped to about 31,000 prescriptions a month. 90% of those are now e-prescribed across the system. And 5 months after go live, we had 126 clinics that were 100% e-prescribing their controlled meds, which to us was very good, and it was surprising too. And it was go live day. We did about 62% of our physicians were identity proofed out of the 2,400 employed physicians. So that was a big step for us too, to make sure they were all there and able to use the system when we took it live. And one of the other things we did was some time efficiency savings. So on average, we've estimated about $850,000 a month. This is ongoing time efficiency savings. We didn't list it as cost savings only because the time that we're saving our providers and our nursing staff from having to deal with a printed script is time that they're using for something more important. So it could be time to go over more messages with patients, time to take care of your patients, having more open appointments. So we didn't list that as cost savings, but we listed that as a time efficiency kind of savings. Lessons learned. So I added this in here because there were some things we wish we would have done better, but it's always that way when you implement a big project. So the first part was the third-party audit. That is something that is done by Epic Corporation unless you do not implement completely Epic Standard. So if you implement Epic Standard but you customize some piece of that, then you're going to have to go out and get your own third-party audit. But your Epic TS can help you with that. That's something, if you have customizations in your system based around medication ordering, get rid of those sooner than later. That took us a little bit of extra time. I wish we would have pulled out some of our own customizations before we started our third-party audit, but start that early and start it in your testing environments. One of the biggest things was execute the service level workflow ahead of go live. So we did the grant and admin request workflow that I had mentioned earlier in this presentation. We did that prior to go live because it was easier for us to put a group of our physician informaticians in a room. We went through and we did an import and added grant to all of our providers. And then we sat with our physician informaticians and went through and approved all of those providers. And then the day of go live, you have to add, if you use SureScripts, you'll add a service level for e-prescribing controlled medications to their SER record. The problem with adding that the day of go live is not every pharmacy updates their provider records every day. We have some pharmacies that they do an update every 48 hours. We have some pharmacies that do an update every 6. The problem with that is when our providers tried to e-prescribe those controls, the pharmacy was sending them back saying the providers were not set up. So you can either add the service level or you can do the grant and admin workflow. You cannot do both before go live. So that's something lesson learned, we would have flip-flopped and given them the service level a day or two before go live, so that way every pharmacy that we used would have had our providers updated within there. Another thing was, as I mentioned in the very beginning, we were in the process of rolling out OneSign. At Geisinger, we call it Taps Care. And it wasn't completely rolled out to all of our hospitals, but if you are going to use native Epic, that's something that it's a better workflow for our providers if there is OneSign on the PCs. If you're using Epic LDAP, it won't make a difference. You won't have that issue that we had. As I mentioned before, the customization piece. Something else I wanted to mention too, since we mentioned our making sure you had a big group for your project team. The other part we did was to involve leadership early and often. We had an extremely engaged and supportive leadership group here at Geisinger for this project. We had informaticians and clinicians that were involved since day one. They helped with testing. They did the workflows. They made sure that the workflows were smooth for our providers before this went out and went live. So that really helped to drive the project. We also had some informaticians and some nurse informaticians that were already familiar with EPCS because they had worked at other places. So it was fantastic to have their knowledge and their experience to help the project to move along. The BYOD program that I mentioned, that program, the Bring Your Own Device one, was pushed from our CEO down. So that was another thing that leadership really helped us with getting our providers to use their own cell phones and devices for this. Identity proofing. At first, we had a few issues with getting our providers identity proofed and them having the time to show up and have it done. But our leadership, that was another piece that they helped us with to push down from the top to make sure we had that 62% of our providers ready to go as soon as we turned on EPCS. One of the last things we did, besides our IT and Geisinger leadership, we involved the Institute and departmental leaders too. So after go live, we were still only at 62%. So we reached out to every single one of the Institute leads and department leads within our system, sent them reports of their providers that were not set up to do EPCS, and then they pushed on their own providers. Because at that time as well, we also had the ops managers ready to do enrollments for us. But I just wanted to reiterate the leadership piece and making sure you have the system behind you before you put in the EPCS project. And I'm going to hand it off to Dan from Imprivata.
Excellent. Thank you, Amanda. That was great stuff, and I see many of you are starting to ask your questions via the Q&A box, so that's great. We'll get to those in just a sec. I just wanted to give a quick overview of Imprivata Confirm ID, which is our solution and the solution that Geisinger and other organizations use to enable EPCS. So we had a little more detail about the technology behind some of the processes and things that Amanda was talking about. So at a high level, Confirm ID is really designed to help you meet all of these different requirements that the DEA has for EPCS. Amanda walked through many of these, but these are unique and specific to EPCS and oftentimes will require adjustments to your existing processes. So Confirm ID is really designed to help you meet all of these different requirements in as automated of a way as possible. And that includes the initial components such as the identity proofing and the enrollment, a lot of the reporting and logical access control support, but also we want to make sure that that two-factor authentication workflow at the time of prescribing is as seamless as possible for your providers so you can really drive adoption and see the benefits of EPCS. So, for example, Amanda mentioned that you have a couple of different options for identity proofing. The most common for health systems is institutional. Because you're an institutional practitioner, you have an organizational DEA number. The DEA allows you to conduct in-house identity proofing for your providers. And Imprivata can support this through a wizard-driven utility built into our technology where you can assign the role of enrollment supervisor. And these are the folks that will actually go out and in person check a photo ID for your providers. The DEA says that at a minimum you need to check a government-issued photo ID against the list of approved providers, and you need to create a record of that. And you can see a screenshot here of what that looks like in the product. As part of the same process, we also have a way of binding the two-factor authentication credentials that the provider will use for EPCS to their identity and allow you to create a record of that so that you can have this nice secure chain of trust through this process. You can see the example here is that the provider's enrolling their fingerprint for biometrics, but you'd also use this same process to enroll the phone-based token Imprivata ID app that enables the push and the hands-free that Amanda spoke about. And so this is a very easy 5-minute process guided by the enrollment supervisor and helping the provider get properly identity proofed and making sure that they get their credentials enrolled properly and bound to their identity, and that you then have a record of that information to comply with the DEA record-keeping requirements. As I mentioned, we really want to make the two-factor authentication process as easy as possible, and we do this in a couple of ways. First, we try to give you as many options as possible for satisfying that two-factor requirement, whether it is biometrics through fingerprint or a token, usually on the phone. But again, that can be a number of different options there, whether it's a conventional token where the provider would type it in, or the push to accept, or the completely wireless hands-free authentication, which Geisinger and others are using. This is going to give you the flexibility to sort of mix and match whichever options are going to best fit your provider's needs, as well as in any given prescribing scenario. For example, you may want the fastest possible options in discharge stations or your ED, but those options may not be feasible for prescribing from home or elsewhere outside the hospital. So Imprivata really tries to give you options that are going to meet all those different scenarios. And the product is always going to know exactly what the provider has available to them at the time of prescribing, and that's all that we'll present. So again, we try to make it easy and seamless and fast as possible for your providers, right in line with their prescribing workflow. And then, from a DEA perspective, there are a number of significant record keeping and reporting and auditing requirements that the DEA has for EPCS. A lot of that functionality is required to be built into your e-prescribing application or your EMR, but there's a number of additional reporting capabilities that Confirm ID will give you that the EMR will not, and some other reports that will supplement what that EMR gives you, so you have a complete holistic picture from a reporting perspective. So for example, Confirm ID will give you audit records of the identity proofing event, the enrollment and issuance of the provider's two-factor credentials, the EPCS access approval for the logical access control step. That's where you're granting permissions within your EMR. And then all kinds of user activity for signing transactions, et cetera, as well as any failed authentications. And you can configure how long you want to retain this information. The DEA and most state laws require 2 years at a minimum, but there are some states, for example, New York requires a longer retention period, and so you can configure the system to do that. And so finally, before I turn it back over to Emily for questions, I just want you all to be aware of what's happening from a regulatory perspective with EPCS. So as you may be aware, there are a number of states that are starting to pass laws that require electronic prescribing for controlled substances. New York was the first. Their iStop law really paved the way for other states to follow. It set the example. And since then, in fact, this actually is outdated already because just this week, Texas and Florida both passed their mandates. So we're actually now up to 26 states that have passed EPCS mandates, and you can see here the deadlines for compliance over the next couple of years. In addition to that, the Support for Patients and Communities Act was signed into federal law in October of last year. And this was a sweeping bill. It had a number of initiatives designed to address opioid abuse. But one of the components was an electronic prescribing requirement for all controlled substances prescribed through a Medicare Part D prescription drug program. And so in order to be reimbursed through those programs for controlled substances, you must prescribe electronically. And that part of the legislation goes into effect in January of 2021. And then finally, Walmart announced last year that beginning in January of 2020, it will only accept prescriptions for controlled substances if they are sent electronically. So if your patient population uses Walmart at all for their pharmacies, just be aware that by January of next year, Walmart is going to require you send electronic prescriptions for all controlled substances. So I just wanted to make everyone aware of what's happening from a regulatory perspective, and it's happening very quickly. So these deadlines are coming up, all of which require you to meet all of those DEA requirements for EPCS. So with that, I will now turn it back over to Emily for questions.
Thank you, Dan and Amanda. That was a fantastic presentation. So as Dan mentioned, we will now begin today's question and answer session. As a quick reminder to our audience, you can submit any questions you have by typing them into the Q&A box on your dashboard. And we'll try to get through as many questions as we have time for today. So with that, it looks like we've got a lot of great questions coming in, so let's go ahead and just get started here. Our first question comes from an audience member who asks, who does the ongoing enrollment as providers are hired or as providers get a new smart device? And Amanda, I think this would be a great one for you.
Yep. So what we do at Geisinger is we have a training team. So when our providers are onboarded, they go through an EPIC training process. That is the first stop for them to get enrolled. If they don't happen to have the the app downloaded or they don't want to enroll at that time, when they get to their clinic or if they are on a hospital rotation, we have right around, I think, 350 enrollment supervisors that are not IT staff. So we have 1 to 2 clinic staff at every single clinic. There are some clinics that they only have 1 enrollment person, and then we have a community practice, best practice team that's over some of our outpatient clinics. They also do some of our enrollments as well. If a provider does not know who in their clinic or who in their hospital does these enrollments, there is a list that our Epic production support team has that has the list of users that are enrollment supervisors and their locations. And then we allow our providers to reach out with them if they would like to set up a time to do the enrollments.
Thank you so much for clarifying that. All right, let's move on to our next question here. So we have an audience member who asks, what required elements are included prior to allowing the physician to prescribe opioids? And Amanda, maybe you can start with this one.
Yep, so hopefully I answer this one the way the user wants. But required elements, so if you use SureScripts, so for us, since that's who we go through, this is just to e-prescribe. The providers need, a fax number, an address, the clinic name. But one of the things that Epic has implemented within the SER record is they will not even allow you to put grant in their SER record for controlled medications unless there is a valid DEA or Social Security number within the provider's record. We do the valid DEA number. That way it goes through SureScripts, and our pharmacy does accept those. We also send over the national provider ID for those providers. Our DEAs, when our DEA numbers, when our providers take a look at those to grant the request, they're also verifying that the provider is set up and does have a DEA that is allowed to do controlled medications, because we can do those by different schedules. It all depends what the provider picks when they get their DEA.
Perfect. That was really helpful. Thanks, Amanda. So this next question I think would be a great one for Dan. Dan, we have an audience member here who asks, does each EMR, so Allscripts, Epic, Greenway, NextGen, pick your flavor there, does each EMR have their own credentials service, or can Imprivata handle the DEA registration and approve use of DEA numbers for EPCS?
Great question. So every EMR or e-prescribing application will have its own specific way of enabling EPCS. Fundamentally, the DEA requires those applications to have certain features and certain capabilities, but exactly how they implement those capabilities does differ from EMR to EMR. Now, the credentialing piece, again, can fall into one of kind of 2 buckets. One is the institutional, where if your organization is an institutional practitioner, if you have an organizational DEA number, the DEA allows you to conduct that identity proofing in-house, typically through your credentialing office or your medical staff office. And there, at a minimum, if you check a government-issued photo ID and you create a record of that, that's the sort of minimum you have to do for that process. That's what Amanda was discussing that they use at Geisinger. That's what I showed you in the Confirm ID slides. We can support that as part of our product. And that's outside of the EMR. That doesn't necessarily happen within the EMR, so that's sort of an outside process. If you use the individual identity proofing, which you have to do if your organization is not an institutional practitioner, then this is where you'd partner with a third-party credential service provider. When the provider would go to that CSP's website, answer a series of questions, and they would be identity proofed on the back end, typically through like an Experian based on their credit history. Now, there are a number of different authorized credential service providers, or CSP, and each EMR will have their own partner from that perspective. Imprivata does offer the individual service through our partner DigiCert, They are a federally approved authority to do that. But depending on what EMR you have, there may be different options. So while it is a little bit fragmented in terms of who you can use to meet all of these requirements that we're talking about to comply, every single EMR and e-prescribing application at this point does have options for EPCS. They have to, given all that's happening from the regulatory perspective. So hopefully that answers that question.
That was perfect. Thank you so much, Dan. So we have a ton of great questions coming in. This next one I'll direct toward Amanda. Amanda, what did you attribute the reduction in overall opioid prescriptions to?
So I think it was a couple factors for us. So when we put in EPCS, it was also right around the same time that we did PDMP for Pennsylvania. So it's the Pennsylvania Drug Monitoring Program. So our providers had to legally check the PDMP before giving any controlled medications to a patient. Having to check that and seeing the controlled medication used by our patients, I think that had a piece of it. We had a lot of providers that going live with EPCS and having their controlled medications reported on and looked at by, I think, other colleagues and then our staff. I think that attributes to how many they're writing for their patients. And then the other piece of that is we had some providers who refused to use their personal devices, and they don't write controlled meds anymore. They will not write them for their patients. They turn their patients to another provider for that. So I think it was a combination of things that lowered that. But I think the biggest one was, implementing EPCS made our providers take a second look at the amount of controlled medication scripts they were given to our patients.
Absolutely. So you mentioned some providers refuse to use their personal devices. A great follow-up to that, what does a provider do if they don't have a smartphone?
So we had some providers that still had some flip phones. We also had some other providers that still had, I think it was that Nextel push-to-talk. And those providers, they're not able to use EPCS. Because we have this BYOD program at Geisinger, and it was in place almost 2 years before we went live, our providers had to have a smartphone per that policy. We also, when we sent out that we were going live on EPCS, Imprivata has a great visual that lets you know which devices their app is compatible with, be it Apple or Android. And that was something as a huge broadcast message to every provider we sent out as this is coming. Here's the type of phones you need to have to be able to use this. And then the BYOD policy went out along with that. But there is a really great visual that Imprivata does it helps providers understand which phones they can use and can't use, including iPads. If any of their providers like to use an iPad and carry that around, as long as it is that user's specific iPad, you can't enroll four users in the same application on one iPad. So if they have an iPad that they like to carry in to see patients and they're the only ones that use it, you can enroll an iPad as well. And Dan might have more information on those devices too.
Dan, do you have anything you'd like to add here?
No, I think you definitely covered it. Thank you. And I think we're always Imprivata anyway. We're always innovating on different ways to make the process as easy as possible. So we are looking for investigating new phone-based authentications that aren't the token. So stay tuned for some potential news on that.
Excellent. Thank you. And we do actually have just one more question about the devices here from the audience. So if a provider changes phones once a phone has been enrolled, do they need to re-enroll with the new phone?
Dan, do you want that one?
Sure. So the answer is yes, they do, in short. And it's because when they get a new phone, they download a new token app with a new serial number. And essentially, it's a new way of authenticating and signing an EPCS order. Therefore, you want to make sure that you bound the identity of that provider properly to that new phone. And so, yes, they must go through identity proofing and have that enrollment of the phone again. So you actually have a couple of different options here that Imprivata can provide if you choose to use Imprivata. One is they can go through enrollment, supervised enrollment again, and they'll go to one of the folks who's designated as an enrollment supervisor. They'll show their ID, we'll create a record, and then you will enroll that new phone. Now, we know that in some cases that may prove difficult just given how frequently providers do get new phones and how many providers you may have and how spread out you may be. So we do have some customers that manage this by having enrollment supervisors in every single one of their facilities. So there's one customer we have that uses every practice manager at their organization in all of their 100, 200 facilities is an enrollment supervisor. And so providers have access to that person wherever they are. The second way that you can do it, though, with Imprivata is through what we call heightened self-enrollment. And if you do this, the provider can actually self-enroll their new phone without having to go through identity proofing again. However, this requires the provider to have another authentication method already enrolled through that supervised process. So most often it's a fingerprint biometric. So what would happen is a provider at the initial enrollment would enroll their fingerprint biometric, and then they would enroll their phone in a supervised way. And then going forward, when they got a new phone, if you enabled this heightened enrollment, they could, on their own, right through the Imprivata agent, use that fingerprint to bind their identity and then enroll that new phone. And it's very fast and it's very easy. A lot of our customers are doing it that way to avoid having to go through the identity proofing. Like I said, though, it does, however, require you to capture that fingerprint at initial enrollment.
Thank you, Dan, for clarifying that. That was really helpful. So we have a couple questions coming in about getting provider buy-in. So Amanda, can you tell us, are your providers employed, and can you talk a little bit about how you got buy-in?
So 2,400 out of those 4,000 providers are employed providers. Our buy-in, I would say, mostly came from our provider informaticians and our leadership team. It was a push down from the top to get our providers to use EPCS and tell them, Geisinger as a whole was going from paper to electronic. And it was something we wanted in and live before Pennsylvania mandated that. It's something our providers can use and get used to. Our providers like to get something early, but even our providers that didn't want to use their own device or were very hard for us to get buy-in from them to do this, those providers ended up. We contacted our leadership team or our providers informaticians, and they had one-on-one conversations with those providers to, take down their concerns, see why they don't want to. That's why I mentioned that on that one slide is to make sure your leadership and your if you have provider informaticians at your organization, make sure they're involved and that they're okay, reaching out to those clinical staff that don't want to use this and aren't sure they want something to be electronic. So hopefully that helps.
Yeah, that's perfect. We do actually have another question more specifically about the finger enrollment process. So this audience member asks, if you got any pushback from providers during that process, especially because you didn't use the fingerprint biometrics or one of the dual-factor authentication. Can you tell us a little more about that?
So, Dan, I'm going to kick this one to you. only because you probably have some organizations that do use the fingerprint enrollment. At Geisinger, we don't. Our providers are, and our leadership team we're not too keen on the cleanliness part of everybody using the same fingerprint reader and that kind of thing. It is something we're looking at now, especially with the enrollment piece that Dan mentioned, that you can, enroll yourself if you've already been enrolled. But we don't use the fingerprint readers anywhere out in our clinics or within our hospital locations.
Yeah, and I think maybe there's some confusion if I'm reading this question right. You don't have to enroll fingerprints if you don't plan to use them, either for signing or the re-enrollment. That's not required for EPCS. That screenshot I showed just happened to be the fingerprint enrollment, but again, that could be the phone as a token instead. And so if you're like Geisinger, and that's all you're using, you're not using fingerprint yet, then that's all you would enroll. You're not going to be asking your providers to enroll their fingerprint when they're not even going to be using it. That said, even for customers who do use fingerprint, there's inevitably some providers who just for whatever reason can't enroll their finger. I will say that the requirements for biometrics for EPCS are much more stringent than, say, for example, the biometrics you might have on your phone. Therefore, a much larger population will be able to be enrolled, and then the false positive and false negative rates are significantly lower. That being said, like I said, there are still going to be inevitably a few folks who, for whatever reason, can't actually enroll their fingerprint. So, you'll want an alternative for them. But like I said, I think the way that this question is asked is, you wouldn't enroll fingerprints unless you're going to actually be using them for something.
Got it. Thank you so much for clarifying that. So this next question is great for, maybe both of you. Are there any suggestions of how to deal with health systems with separate medical staff offices at each hospital? So would you recommend a centralized medical staff office so that the office could identity proof for all locations, or do you do that individually?
Sorry, Emily, I'm just rereading that question because I caught the tail end of it. It skipped out for a second.
Oh, I'm sorry. I will repeat the question real quick. So this audience member asks, are there any suggestions of how to deal with health systems with separate medical staff offices at each hospital? So would you recommend a centralized medical staff office so that the office could identity proof for all locations?
If I'm understanding this correctly, I would recommend that you have staff at each location. I wouldn't centralize it and have the staff come to you. I would have the identity proofing being able to be done at each location instead of a centralized location.
Yeah, and I would agree with that, Amanda, for both the initial enrollment, if you can organize it, as well as the ongoing for new providers, or like I said, a provider gets a new phone and you don't have that self-enrollment enabled. We have plenty of organizations that do it either way and a number of ways in between. But there's no limitation or DEA requirements on who exactly can do those enrollments. So you could leverage that to have as many folks as you'd like.
Thank you. That was helpful. So this next question, we have an audience member who says that his credentialing office currently does credentialing online rather than in person. So he asks, which department performs in-person identity proofing, and do prescribers have to complete EPIC training before going through identity proofing or two-factor authentication enrollment? Maybe we can just start with which department performs in-person identity proofing.
So the in-person identity proofing is the users that we mentioned, like our ops managers, front office staff, nursing staff. This is where we have at least 1 or 2 people at every clinic, and then a big group of people at every hospital location that does the in-person identity proofing for those providers.
Okay, excellent. And then Amanda, do prescribers have to complete EPIC training before they go through the identity proofing process?
No, they don't. We don't force you to take the training. We hope that you do. It's going to help you, but we can't force our providers to take training for medication-related prescribing. There is a training for them already that shows them how to use e-prescribing. This is just an add-on to that training, but we didn't require it for every provider to take.
Perfect. Thank you for clarifying that. So this next one is about the use of hard tokens. So Amanda, can you talk a little bit more about why you opted not to use any hard tokens? And did you order any for backup in case a phone was lost or broken?
So we didn't order any as a backup. If we have the providers who they have to use a personal device, they use the Imprivata ID. We are in the process of implementing too that providers are still going to be able to print. It's going to be a technical malfunction if they don't have their phones or for some reason if it's broken. Our providers, we had some tokens and some fobs that we used for remote access. It wasn't as easy to access as the Imprivata app. When our providers saw that they could use that Bluetooth dongle that plugs into the USB, they turn their phone on before they start their shift, they put it in their pocket, and they go. And their second authentication is they don't have to type in a fob number. They don't have to push approve on their phone if the dongle's there. They loved it. That's what pretty much sold our providers and our leadership staff. It was the ease of use, it was quick for our patients, and it was quick for the providers.
Absolutely. Okay, so it looks like we have time for just one more question. The last question here is about e-prescribing failures. So who monitors those? Can you talk a little bit about that?
Yep. So there's going to be 2 reports that you have to do for EPCS that Epic gives you in a reporting workbench. The first report is your provider report. So every single provider in your system will get has to be given the monthly report for all the controlled meds that they prescribed in that month. And it has to be given to them within 7 days after the end of the month. There's no legal ramifications whether the provider looks at it or not. You just legally have to make it available to them to look at. They can also run that report ad hoc. And the other report is our EPCS failures with the providers using the first and second factor authentication. So there's a report for that Epic pulls in as well. That one you legally have to look at every day. Myself and another member of my team, between the 2 of us, we take care of that every morning. If any of our providers, we did a policy at Geisinger, if a provider tries to use 2-factor authentication and they do it wrong more than 5 times, we will send them an email and make sure that it was them, they were trying to use it, and then reinforce, if they were typing their password in wrong or try to figure out if there was an issue with their phone. And our interface team, they also monitor our e-prescribing failures on the interface. Our prod support team also monitors a work queue for e-prescribing failures and to see if there's some of the same errors in a row, because sometimes, you have issues with the pharmacies as well. So between our application teams and our interface team and our production support team, we keep an eye on all of the failures between each of us.
Thanks, Amanda. That was helpful. So that was the last question we have time for today. Amanda or Dan, do either of you have any final thoughts for the audience?
Well, I think I would just say, those are all great questions. Thank you, everyone, for your interest. I would just want to reiterate, though, about those coming deadlines. Hopefully, what you came away with here is that EPCS is absolutely doable, but it does take planning in a number of departments of your organization. Not something you can just turn on overnight. So given all of those pending deadlines, really start working backwards and planning your projects as early as you can to make sure that you're in good shape once those deadlines hit, because I don't think you want to be scrambling to try to complete this as we get much closer to those deadlines.
And I agree with Dan, early is better, and surround yourself with a good group from the top of your organization all the way down to the users. And it's going to make your workflows and implementation a lot easier. And thanks for attending.
Thanks so much, Amanda and Dan. So that's all the time we have today. I would just like to thank both of you for this excellent presentation and thank Imprivata for sponsoring today's webinar. To our audience, please enjoy the rest of your day, and we look forward to having you join us for future webinars.